PCOS has been renamed. One letter changed, but that one letter means so much to millions of women living with this condition and millions more who didn't even know that they have it yet. This is incredibly significant. Today, we're going to cover what PMOS actually is, why the name change matters more than a lot of people think, and how this condition affects women's bodies and weight specifically. And then I'm going to go give you real practical nutrition and exercise takeaways that you can use this week. Welcome back to the Mindset Mirror Connection podcast. Welcome to the Mindset Mirror Connection podcast, the podcast where we have honest conversations about food, body, exercise, and mindset. I'm your host, Christina Hathaway, licensed associate marriage and family therapist with specialized training in food and body obsession, certified personal trainer and nutrition coach. And we have candid conversations about how your mind, your body, and your identity are one integrated system and teach you how to treat it accordingly. So if you're a high-performing individual who loves educational, thoughtful, and no bullshit conversations around health and wellness, you're in the right place. Here we believe what you say in your mind, you see in the mirror. So let's have a conversation about that. What's up, guys? Welcome back to the Mindset Mirror Connection podcast. I'm so excited that you took this time out for yourself to learn something about your physical and mental health. And today we're talking about something that just dropped in May 2026, published in The Lancet, and I have not stopped reading about it since. PCOS, which stood for Polycystic Ovarian Syndrome, has officially been renamed to PMOS, Polyendocrine Metabolic Ovarian Syndrome. The name change came after more than a decade's time of work. Over 22,000 people responded to surveys. More than 50 patient and professional organizations were involved, including the Endocrine Society. And the paper was published in The Lancet and presented at the European Congress of Endocrinology in Prague. And this is not a casual rebrand, guys. This was literally like a global consensus that said the name that we have been using for decades is absolutely wrong, and it ultimately was hurting people. So let's get into like what was wrong with the old name. I want to say a lot of the clients that I work with, I would say probably about 10% of my clientele do struggle with PMOS or PCOS, formerly known as. And it can create a lot of struggles, especially when it comes to weight and understanding it. Obviously, I am someone who has had cysts on my ovaries, but I do not qualify for PCOS, whereas some of my clients who have the diagnosis don't have cysts on their ovaries. So we're going to talk about all that. So polycystic ovarian syndrome implied that this condition was defined by cysts on the ovaries, right? And the problem is that many of these women with the condition, again, don't have cysts at all. And even when they do, they aren't actually pathologically cysts in the traditional sense, because the name itself pointed to the ovaries, right? Ovaries and two cysts, and doctors and patients both defaulted in treating it as a gynecological disorder. This could also be, I guess, looked at as a reproductive issue as well. But something that you addressed, when you're trying to get pregnant, when your periods are irregular, really your OBGYN would address this. That framing actually left out nearly everything else that was happening in the body. And it caused me a lot of frustration in working with clients. But the new name takes on a completely different approach, because polyendocrine means multiple hormone systems. So multiple systems are involved, not just the reproductive system. And when you're thinking about this, I want you guys to think about cortisol, insulin, testosterone, thyroid. These are all endocrine systems involved. Metabolic means a condition that has a significant impact on how the body processes energy. This energy, of course, is food, right? And with food and PMOS and any sort of metabolic issue in general, insulin resistance, blood sugar regulation, cardiovascular risk, and weight management all become part of the picture when we bring metabolism or metabolic into the name. The ovarian part of it does acknowledge that, yes, the ovaries are involved, but they are a piece of a much larger system that is ultimately dysregulated. One reproductive endocrinologist at Yale described this shift as moving from a microscopic to a telescopic view. That framing stopped me when I heard it, because that's exactly what this is, right? And it makes more sense for me as a coach. We stopped kind of squinting at one piece, which was the ovaries, and zoomed out to everything else. And I'm so happy that we're making these changes for women and we're listening to women, and that there are enough physicians who are advocating for these changes. So here's what this change formally acknowledges. Okay. So a lot of my clients often felt dismissed when they'd come to the doctor with their symptoms. PMOS is not a reproductive disorder. It does not happen. It's let me say it this way. It's not a reproductive disorder that has some metabolic effects. It is complex. It's a multi-system hormonal and metabolic condition that happens to affect reproductive function. And that distinction, that change, it really changes everything about how women will be diagnosed, treated, and how it will be managed. Because for a long time, women were told that their irregular periods were the main problem. Fix your cycle, focus on fertility, come back when you want to get pregnant. I hear that over and over again. And the metabolic issues, or metabolic crisis really, that was happening underneath, again, the insulin resistance, chronic inflammation, cardiovascular risk, and changes in weight, those were often treated as like secondary issues or not treated at all, which is crazy. This new name formally requires the clinicians access to treat the full picture, the full person. Irregular periods, we want to check their blood glucose, their blood pressure, alongside with understanding their hormonal picture. And that's really, really good news for all women around the world. And here's what I find interesting is that the Global Name Change Consortium, which I think I'm saying right, said that the old name is contributing to delayed diagnosis, fragmented care, and ultimately stigma, while curtailing research and, of course, policy framing. Delayed diagnosis, fragmented care, and stigma. I mean, talk about anything that has to do with women's health. That's a lived experience that millions of women have spent years, if not decades, told something was wrong with them without giving them the full picture of what they could do to help them. That's nuts. But again, this is how we treat women in the medical field. So we're going to call this a win. So obviously here we talk a lot about weight and diet and all that. So I want to talk about the weight conversation in regards to PMOS, because I want those listeners who have PMOS to understand the scale and what you're dealing with. So PMOS affects about 1 in 8 to 1 in 10 women of reproductive age, and that is more than 107 million women worldwide. The WHO, the World Health Organization, estimates that 70% of people with the condition are undiagnosed. 70%. That means the majority of women right now with PMOS have no fucking clue that they have it. So let's talk about symptoms just in case. Of course, yes, irregular or absent periods, right? Which that could be for a lot of reasons, but with these other symptoms grouped together, it most likely is PMOS. We have acne, thinning of the hair, but then facial hair growth, fertility changes, mood dysregulation, including heightened anxiety and depression. And the one thing that clients usually come to me or doctors about is also their weight. Okay. Because this is where I think the conversation gets the most distorted and the most damaging for these women. Women with PMOS are frequently told just lose weight, that losing weight will help regulate your hormone. And I guess regulate your hormones, then your cycle, right? And while there is some truth and connection between body composition and hormone regulation, the directive without context is just incredibly cruel, right? So let's give you some fucking context. The root driver, the catalyst for most women with PMOS is insulin resistance. I've talked about this before. This is when the body produces insulin but cannot use it efficiently. The pancreas overproduces insulin to compensate. That excess insulin signals to the ovaries to produce more androgens, which are male-type hormones like testosterone. And elevated androgens, promote fat storage. particularly in the abdomen, making fat loss incredibly harder. And also, when it's in our abdomen, that increases the likelihood of cardiovascular risk and all-cause mortality. This is importante. So, you go in, you talk about your symptoms, the doctor tells you to lose weight, but the condition itself is making weight loss physiologically more difficult than someone without insulin resistance. Then when the weight doesn't come off, the assumption, of course, is you're not trying hard enough. You're not eating right. You're lazy. You don't have willpower. And then the vicious cycle happens over and over again when the fucking cycle is not accurate. I'm fueled on this, y'all, but I'm very happy. Weight gain of PMOS is largely driven by the hormonal dysregulation in the person's body, not a lack of effort. That means that body composition changes, like losing weight, almost become impossible. They're possible, but the approach has to match the actual problem, not and the actual problem again is metabolic. It's not motivation, right? It's not discipline. And again, women with PMOS have a significantly elevated chance of getting type 2 diabetes, again, having cardiovascular disease, and having metabolic syndrome. And so this is not a cosmetic condition. This is a long-term health risk that requires sustainable management. And I get to help you with that. So let's talk about how I'm approaching my clients with PMOS using this information and what you can do today. So when it comes to nutrition, PMOS is fundamentally a metabolic condition driven by insulin resistance. Nutrition is one of the most powerful tools that we have. And the goal is not restriction. The goal is blood sugar stabilization and reducing chronic insulin spikes. So what does that look like? Good news, we already talked about some of these things. Protein needs to be the anchor at every single meal. High protein meals slow glucose absorption, they reduce insulin response, and they keep you satisfied longer. We want to aim for 25 to 40 grams of protein per meal. I need you to hear that this is a non-negotiable. If you follow me on Instagram or TikTok, I give you so many high protein options that you can get from the stores you shop at. I have all of them listed there. And for those of you who are interested, our collective, next cohort of the collective will start in September, where you're going to get all of that information: breakfast, lunch, dinner, snacks on high protein and high fiber. And we can also make a low glycemic index, which I'm going to talk about next, style foods that are going to be that anchor for you so that you don't have to rewrite a whole menu. We make it very, very simple for you, but it's free. All those things are on my social media. So let's talk about carbs, because quality carbs matter more than the quantity of carbs. Low glycemic carbohydrates like sweet potatoes, oats, quinoa, non-starchy vegetables are far better tolerated than refined carbs and added sugar. So you do not have to eliminate carbs. You have to choose your carbs thoroughly and always, always, always pair them with a protein or fat. Why? Empty carbs spike blood sugar. When we pair them with a protein or a fat and we pull off of that low glycemic index, then we are going to help maintain your blood sugar. I have a client with PMOS, and she and I had a conversation this past week. I said, look, back in the day, they used to say a low carb diet. I believe in the study I was quoting for her, it was 30 grams a day, which is crazy. Does help for a shortened period of time, does help with the symptoms of PMOS. However, she is not ready to do that. This client does know she oftentimes has a lot of sugar in her diet. She oftentimes will eat refined carbs. So I said, look, let's first and foremost give you a carb goal, because at the time we just had a protein goal. So right now we're working on a carb goal. Then the next thing we're going to layer on top of that is replacing those refined carbs and sugars with some of these low glycemic carbs, which does include things like strawberries and blueberries and raspberries, which I know you guys are gonna be like, you're fucking crazy, but there's fruit, low glycemic fruit, and those are also high fiber foods, are so delicious. Like when you need a sweet treat, there's nothing to me that satisfies me better because they're so good, but then I feel good after them. So this belief that we need to go gluten-free, we need to go carb-free, that's not what we need to do. We need to have high quality, low glycemic carbohydrates instead. Are you tired of wasting your money on diet and exercise program that leave you feeling pretty much the same? You're spinning your wheels, but the food noise is still there, the body dysmorphia, the overtraining and not seeing results, the emotional eating, it's all still there. But you don't think you have an option because they're pretty much all the same. What if the next program you invest in combines therapeutic practice with exercise and nutrition science and behavioral change? What if this program focuses on what you say in your mind so that you can have a better relationship on what you see in the mirror? Hi, I'm Christina Hathaway, licensed therapist with specialized training in food and body obsession, certified personal trainer and nutrition coach, and I'm the founder of the Mindset and Matter coaching program. Here, we see your mind, your body, and your identity as one integrated system and treat it as such. We focus on your self-defeating beliefs and understand how they impact your behaviors and thus the outcomes that you feel stuck in. We do this through the Mindset Method, my psychological curriculum that I've curated with over 15 years experience and adapted it to you, the average woman, and this coaching program. This is one method, one program, one coach, and let's face it, the one area you've probably never done the work on. So if you're tired of spinning your wheels and wasting your money, check out the link below for more information. Next is anti-inflammatory foods as a secondary layer. So there's your omega-3s like salmon, sardines, walnuts, and flaxseed. They will help reduce chronic low-grade inflammation that worsens PMOS symptoms. Things like extra virgin olive oils, again, berries and leafy greens, and even like herbs like turmeric and ginger will all fall into this category. So what you're hearing me say is protein first, yummy low glycemic carbohydrates, and some yummy fats. This morning, I literally had a high fiber bagel, some Laughing Cow, and some smoked salmon. I've been eating a lot of fish lately. So I looked up, I was like, am I going to get a parasite? I love omega-3s. They're nature's delicious little medicine. And all of the things we're talking about is medicine for your symptoms. But also meal timing really counts. Skipping meals causes blood sugar crashes followed by blood sugar spikes. So when we're eating erratically, basically our insulin is going to stay unstable, and that's obviously going to be a problem. And it doesn't mean you have to eat at the same exact time, but if you're someone in the habit of going like 6-7 hours without eating a large meal, that is a big problem. Also a big problem, ultra processed foods, excess added sugar, alcohol, and of course, long gaps between meals. These are 4 things that will amplify insulin resistance and your PMOS symptoms. You'll hear a lot about supplements, so let's talk about the ones that research they're most researched in regards to PMOS. Myo-inositol, specifically in combination with the combination of myo-inositol and D-chiro-inositol, is one of the most researched supplement combinations for PMOS. This helps improve insulin sensitivity, and in some studies, it will help restore ovulation. This is not a replacement for nutrition changes, but if we have the nutrition changes, it can be a meaningful little bit of something else that will be helpful. Things like magnesium and vitamin D deficiencies are also extremely common for women with PMOS. Both play a role in insulin resistance and hormonal regulation, and it's worth you getting a metabolic lab work done so that you can see where these levels are in your body. And I want you to, for those of you listening to this, you're like, okay, I think I can do this. I want you to just reframe this. It's not a diet. This is your hormonal management protocol, just as someone with type 2 diabetes would have a nutritional protocol that they have to follow. And the good news is we're not leaving any type of food out. we're just replacing foods and trying not to have added refined carbs and refined sugars. So that is nutrition. Let's talk about exercise, because it is one of the most powerful interventions on PMOS, and the research is incredibly clear and backs this up. Of course, as always, strength training is going to be your priority. Resistance training increases glucose uptake in muscle tissues directly, okay? What this means, it improves insulin sensitivity independent of weight loss. You do not have to lose weight first for exercise to start working for you. The exercise is the part that gets you there. So 2 to 4 sessions of weekly compound movements, squats, deadlifts, rows, presses is the evidence-based recommendation. If you're not strength training right now and you have PMOS, this is absolutely the first thing to add. Check the show notes below. I can help you with that. Another thing is daily walking. Daily walking is very underrated, but very well researched. Low intensity, steady state movement, walking, cycling, swimming does not spike cortisol and has strong data for blood sugar management. A 10 to 20 minute walk after meals has been shown to reduce, post-meal glucose spikes, which is incredibly meaningful. This is a simple, low barrier action that you can do even with a little bit amount of time. Now, for some people, they talk about high intensity interval training and PMOS, but when I was looking at the research, the results are actually kind of mixed. So for some women, it is beneficial. For other women, particularly those who already have they're just chronically stressed or sleep deprived, high intensity work actually will elevate cortisol worse, drive up those androgens, and that obviously is the opposite effect of what we want. So HIIT is not on or off the table, but it should not be the foundation of your protocol. If you're already fucking tired and exhausted, HIIT is not going to help you, especially with PMOS, just like overtraining can also be a big risk, right? Many women with PMOS have been told their whole lives that they need to work harder to see results. So they do more cardio, they do more intensity, there's more restriction, and that approach backfires because stress, it puts stress on the body, which again raises your cortisol levels. It raises those androgens and pushes that hormonal word's hard for me to say. It pushes that hormonal environment further out of balance. Rest is not a reward for anyone. Recovery actually needs to be a part of this protocol. So the takeaway really for exercise is building the foundation with strength training and daily movement, layer in HIIT when your stress load is low, and of course, at all costs, please protect that sleep, okay? I wanted to add here, though, what are some other health habits that we can do to support PMOS management? Nutrition and exercise are obviously our 2 biggest levers, but they do not work in isolation. So I already kind of touched on this, but these are other habits that help move the needle. Sleep is a hormonal regulator. Let me say it again. Sleep is a hormonal regulator. Poor sleep increases cortisol. It worsens insulin resistance, and it elevates hunger hormones. So women with PMOS who are not sleeping well are fighting an uphill battle regardless of how well they eat or train. 7 to 9 hours is the target. If sleep is disrupted, it is really one of the first things that we want to address with PMOS. The same as stress management, because obviously chronic psychological stress keeps our cortisol elevated, which keeps our androgens elevated, which keeps hormonal dysregulation running. I mean, I sound like a fucking broken record. And now we can't eliminate stress, but it's about building a regulated nervous system process so that we can process stress, get out of it without staying stuck. These are things like boundaries, breath work, some gentle movement, time outside, getting some sunshine on your face. Whatever brings your nervous system down from high alert is part of your PMOS protocol. Now, this next one is something that you may want to work with someone on, but gut health matters more with women with PMOS. There's emerging research that's connecting gut microbiome health to insulin sensitivity and inflammation in PMOS. So increasing fiber with whole food sources. What did I say? I did not say Metamucil. Stop doing that. Whole food sources, which looks like adding fermented foods like Greek yogurt, protein, kimchi, sauerkraut, and again, reducing ultra processed foods so that your gut, you support this kind of healthier gut environment. And that is going to help you in way more ways than just PMOS, because we say, your gut is your second brain. I think it's your first brain, honestly. The other thing I want to do is limit endocrine disruptors. So this one is less discussed about, but I wanted to put it in here when I was doing my research and my notes. So certain chemicals found in plastics, pesticides, and personal hygiene products can interfere with hormone signaling. So switching to glass or stainless steel food storage, choosing produce from the Clean 15 list, which I'll put below, and reading ingredient labels on beauty products are just a small step to reduce your overall hormonal burden, but you don't need to become, live in a, what is it called? Live in like one of those, remember that movie Outbreak when they the CDC walks in their little suits? You don't need to be that person. But what you do need to do is advocate for your care. The name change came in part to patients who spent decades being dismissed, underdiagnosed, and undertreated. Again, 70% don't know that they have it. So if your periods are irregular, if you have persistent unexplained weight changes, acne that doesn't respond to treatment, mood instability that feels hormonally driven, ask your doctor specifically about PMOS and ask for that metabolic workup. Now, what does that look like? Now, I am not a doctor, but I am someone who works with a doctor on this exact thing. We want your reproductive hormones, so estrogen, progesterone, testosterone, DHEA. We want to see cortisol levels, inflammatory markers. I would get your thyroid tested. And listen to me, you guys. We're not just getting the TSH tested. We want to see T3, T4. We want a full metabolic panel, because what you guys don't understand is that when you get blood work at that preventative, what's it called? Physical, it's not looking at any of that. These are things we need to ask for, and you can advocate for them. And if your doctor is not listening to you, you need to find another physician. Once you have that blood work, and I always like people to get it done up front, because you want to see if what we're doing is working. Then we make the changes, whether it's, all the things we talked about, the nutrition, the exercise, the supplements, the sleep habits, stress management, all of that, which all of that is good for everyone. So I don't want you to feel like, oh my God, I have to make all these changes. Honestly, everyone should be eating and being in this way most of the time. Then as you go on, you can continue to get those tests and see if what you're doing is working. And the goal ultimately is, of course, to help with body composition, because again, we have this weight gain that is a long-term health risk, which if you're new here, that is something that is really important to me, that we're taking care of ourselves now. It's kind of funny. I had a meeting with a 28-year-old, and it was so cool. She's like, I want to be able to be independent when I'm 70. And I'm so glad to hear our young girlies, at least her, are interested in that. And so I hope she works with me, because I get so geeked out by being a mentor for these young individuals. But if you're young or, even in midlife, you have to think about the fact that you have this diagnosis that is a health risk, especially with the additional weight gain around the abdomen. Any sort of additional weight gain around the abdomen puts us at a higher risk for all-cause mortality. So this is incredibly important, and we don't have to do it all at once. Where I would start is with nutrition, like I did with my client. Let's just start subbing out some of these refined carbohydrates with the low glycemic index carbohydrates and making sure we're pairing them. So I would start with that swap and no naked carbs. Start there, and then making sure you're eating every 3 to 4 hours. It's incredibly important. It needs to be a routine. If you are someone who's like, I just can't do that, this, that, the other, then you have to accept the reality of how your body is going to respond. If you need help with that, that's where coaching comes in. Where coaching comes in says, let me help you figure out the easiest way to get here. And for this particular client, we have both meal prep ideas that are super fast for her. She owns her own company. She has multiple employees. She does a lot. We have foods that we prep, and we do have a list of fast food places that she can go to and what she should order, because her job requires her to be in different locations. She's already strength training, so we've got that done. She plays a little bit of pickleball and walks her dogs. She actually owns a dog walking service, even though she's not necessarily walking the employees walk the dogs, but she walks her own dogs. But I will say the biggest thing was the sugar, the refined carbs, and the food timing. So we're still going to work on that. It's just it needs to be one thing at a time, where you feel like, okay, I've got a grasp on this. I have the capacity, because say you're changing to lower glycemic foods, do it over time. And once it feels like it's a default and you now have capacity to take on something else, then add the next thing. You get too overwhelmed when you try to change everything at once. It is overwhelming. So do one thing at a time. This is a shorter episode, but I just think that, it's not that short, but I really want you guys to be thinking about what this change means to all of us, right? And as I mentioned earlier, in women's health, we have been dismissed, and this is our first win. And I'm excited to see how research and treatment changes for my girlies with PCOS, because it is a very frustrating diagnosis to have, or our syndrome to have. And I'm just happy with that. So the name changed because the old name was wrong. And that wrongness really had consequences. It really, really did, for so many women, for my clients, and even me as a trainer, because we were really missing the mark. And I never did this, but I know a lot of clients I'd have to process the shame around the weight that had nothing to do with their willpower. I think of one of my clients who actually just had a baby, I think in January. She left like 3 or 4 months before she had the baby, but she did everything that I told her to do. And, we followed a lot of these protocols. However, she really struggled. And there was just some other things that we had to add on before her body composition started changing. So it is a metabolic and hormonal condition. Okay. It is manageable. The tools with nutrition is what we're going to build around. Okay. Blood sugar stability, strength training, sleep, and stress management, plus those walks, are available to you right now. And if you're someone who maybe doesn't even know that they have this, and you're listening to what I'm saying here, these are easy changes that you can make. And here's the thing: you make them, if you have PMOS or not, they're going to be great changes to make. I find it very interesting, you guys, how a lot of what I talk about, whether it's perimenopause, Hashimoto's, PMOS, really has a very similar foundation around it. It is health. It's healthy, right? And we have shit on it because we think it's dieting. It's not dieting. This is giving your body what it needs for it to properly perform in the way that it's supposed to. It's gotten out of whack because of the PMOS, and we want to get it back to the new normal. It may not always be the same as it was prior to these changes in your metabolism and hormonal panels, but we'll get it as close as possible, right? So I know this was a quickie, but I hope you guys found this helpful. I really just wanted to touch base on it today. Maybe some of you didn't even realize that the name had changed. But for those of you, I have a handful of clients that I'm working with right now that really are seeing amazing amazing changes in the way they feel, in the way that they look, and in their symptoms. And we're just following this simple protocol. We're no more of the days or cutting out the dairy and cutting out the glucose, or not glucose, gluten. If we don't have to. If we don't have to do it, great. We don't have to do it. I also work with Dr. Jordan Trapp. She does utilize GLP-1s for women with PCOS or PMOS, just for the insulin resistance and inflammatory improvements that it can bring. That's also something that we can look at here, because we have to remember that things like Ozempic are used for type 2 diabetes. So from my understanding, again, this is just per Dr. Trapp, being able to microdose or do a lower dosage of them is incredibly important. I wanted to say something on that. I don't know what I was reading the other day, but they were talking about how GLP-1 dosing should not be fixed, because for some people that first 0.25 could be too much for what they need. So I like working with a naturopath because we can play with the dosing. I do that with my testosterone that I'm on. I play with the dosing because, I want to make sure that I feel it and I sustain it, because we were doing it every 2 weeks. But what we did is cut it down to every week, but just cut down the amount that I was taking. And that's been really great, because at a certain point in that 2-week period, I would crash because the testosterone would drop. So that's why I like working with Dr. Jordan Trapp. So if you want information on her, I'll put her information down below. So that's it, guys. I hope you found this very helpful. If you loved this information, or you know someone who has been struggling, please share this podcast. It's one of the easiest ways to help promote me and what I do here, on top of making sure you hit that follow button if you're listening on Spotify or iTunes, or Apple Podcasts, I should say. And if you're watching on YouTube, hit that subscribe button. It is the easiest way to help us, because when you do that, what it does, it says, okay, this demographic likes this information, and then they send it out or kind of like show it to other people in our demographic to help them. So if you could kindly do that, I would absolutely appreciate that. And it helps so many other ladies learn more about what we do here, and men. We have men that listen too. So thank you guys for listening. I hope you found this very, very helpful. And I'm going to leave you the same way I do every single week, reminding you that what you say in your mind, you see in the mirror. Bye-bye.